on. Good morning, everyone. Welcome to this Q visit on adopting innovation and implementing an innovation hub with Cambridgeshire and Peterborough ICB. It's lovely to have you all here. I'm Vicky Purwell. I'm from the Visits Collective. We work with the Health Foundation to develop visits like this for the Q community. Katie Young is also here from the Health Foundation, and she will tell you a little bit more about the Q and the Q community in a moment if you don't already know about it. Also, Julia Slay is here, my colleague from the Visits Collective, giving you a wave there. Julia and I will be looking after you through this visit. I will be kind of keeping an eye on time and doing some introductions and closing us off at the end. Julia's going to be helping on tech. So if anybody's got any questions, please message either of us in the chat. And I don't have much more to say for now. This is the agenda that you can see on the screen. We've got lots and lots of input, which is partly why I'm not going to say very much now. We've also got a break at around 11:10, and we will also have a chance to have some discussion in breakout rooms later on, where you'll get a chance to discuss and reflect what you're hearing and what this means for you in your context, and have a chance to share some of that back. We are super grateful to Cambridgeshire and Peterborough ICB for hosting us and for their partners. We've got lots of people for you to hear from today. I'm going to kind of call some names out. You'll get to meet everyone as we go, but like if you will kind of give a little wave. So thank you and welcome to Emma, Maddie, Helen, Louis, Matthew, Val, Sophia, Araminta and Simon from our hosts. So you're going to get lots of great voices and experience to hear from today. And also Candida has just joined. Hi, Candida from the Health Foundation, who is also going to tell us a little bit about the Innovation Hub programme, which supported the work that you're going to hear about today. So we are going to have a chance in a moment to introduce each other a little bit more in small groups. But before we set that up, can I invite Katie? Do you want to tell us a little bit about Q and Q membership for those who don't know about it?
Yeah, thanks, Vicky. So yeah, I'm Q's Learning and Development Manager. Really great to see everyone here today. And I know there's a handful of non-Q members who are on the call. So I thought I'll quickly take the opportunity to plug Q membership, and hopefully it'll also be a reminder for members too. But if you haven't already heard about Q, then we're a community of about 6,000 people dedicated to driving positive change. People always tell us that they love connecting with others who are also carrying out improvement work and enjoy accessing our free events and visits like this. So we have lots of networking opportunities and learning resources and lots of different things. So you can join for free and get access to member exclusive funding opportunities as well. So if you'd like to know more, there's a QR code actually on the next slide. Yeah, please do feel free to sign up. We have lots of webinars, workshops, toolkits, an extensive range of different online groups for you to connect with people. So to access more fantastic learning opportunities like this brilliant Q visit, please do join us and become a member. We'd love to have you join us. Thank you.
Lovely. Thank you, Katie. So we're going to just take about 5 minutes now in groups of 2 or 3 to give you a chance to do some of that connection that Katie just mentioned, and to share kind of who you are and what's brought you to this visit today. We've got kind of 2 prompt questions that relate to the visit that we thought would be interesting for you to share. So one is, what does innovation mean to you? And secondly, how do you use innovation? So feel free to answer one or both of those together when we put you in a room. Julia, do we have breakout rooms ready? Brilliant. So we are going to put you in some breakout rooms for about 5 minutes. You'll get a kind of 1 minute warning before the breakout rooms close, so you won't be too abruptly thrown out, hopefully. So you should get, oh, sorry, go on, Julia.
I was just going to say I'll open them now, but of course, if you'd rather stay in the main room and have a moment silent and solo, or if you've got something going on in the background, you're welcome to do so. You can just reject the pop-up.
Absolutely. So if you want to do that, the questions that I mentioned, what does innovation mean to you and how do you use innovation, are in the chat. So if you want to do some solo reflection on that, that's also fine. So you should get an invitation to join breakout rooms now.
Yeah, just coming up now. There we go.
Again. So welcome back, everybody. I'm going to hand over now to Candida to tell us a little bit about the Adopting Innovation programme from the Health Foundation. Thanks, Maddie, for sharing the slides. So
Thank you.
Candida, over to you.
Yeah, maybe we'll just go. I will then, we can go to the next slide. This is just to give you a bit of an overview of the Adopting Innovation programme and where it came from and some of our thinking around this area. So, the Adopting Innovation programme builds on, our work exploring some of the challenges of innovation, and particularly the spread challenge. We found that there's several barriers to achieving spread of innovation, and there's a huge focus on the kind of creation of innovation, but and the NHS probably doesn't suffer from a lack of innovation, but where we see the impact challenges is about thinking about the adoption, particularly how you adapt low innovations to the local context, and also the cultural aspects that kind of lead to challenges of adoption of innovation. So the idea of that not made around here or not from this way is a real important challenge when we think about innovation and its ability to make impact. So we were really keen to try to understand how you can accelerate the adoption of innovation. In the first instance, so the next slide, in the first instance, we thought about its design in the sense that it should be thinking about the adoption of innovation across systems and across providers. So really focus on the local pull. So, one of the ideas that we had was that actually innovation is very much focused on, developers going away in a bit of a darkened room, trying to fill an intervention, but not really thinking about it across the pathway of care, or not really thinking about the population need. So how do we ensure that innovations are kind of pulled from the system and adapted to the local context? And that would be a huge precursor to ensuring that innovation was kind of used and impactful. But equally, we also wanted to not just add something to the system, another thing, another piece of complexity. So we were very keen to ensure that the hubs, which are based in the provider organization, had strong relationships across their system, whether that be with their ASHN or latterly their ICS, and also their academic entities, because we recognize that in order to make innovation, the adoption of innovation work, that it needed to be collaborative and there needed to be a need. And we were really keen to kind of, focus on local health systems, sharing insights and reach across the piece. And we think Cambridge and Peterborough is a fantastic example. The next slide, please. So this is just an initial overview of the sites. We identified 4 sites based in providers initially. So Manchester University NHS-FT, who had a system partner with the Health Innovation Manchester, and that really was focusing on digital technology and digital transformation. And we know at the time that electric health records was really important in terms of spearheading digital enabled models of care and really trying to think about the foundational pieces for more innovative technologies. We had Bradford Teaching Hospital, who was very much focusing on the Aging Well initiative. They had a lot of people who were frail and elderly quite early on, and we saw like increased mobility, but earlier on into the years. And that was a really interesting piece. And one of the interesting pieces of that was that actually, when you do innovation and you're working with systems, it can be quite difficult. So you do have to, there may sometimes need to be reset. So we can share the insights maybe for another visit from that. And then we worked with University Hospitals NHS Dorset, who subsequently then their hub has subsequently moved into the ICS territory. And their, piece, Dorset is one of the first kind of SDPs of the day, have had really strong working local health system working, and they have a huge aging population. So how did you support adoption to the local priorities, but also thinking about the medtech mandate? But last but not of least, one of the really interesting pieces which you'll go on to speak to today was Cambridge and Peterborough, which has been a really interesting case about how you have a really big innovation center, but actually to the top of the health system there are massive inequalities. So how do we support adoption and spread across the piece? And but equally, how do you look forward to some of the really big challenges about new care models and retrofit and create a system for the future? I'm sure that Louis and Emma will be speaking very well to that. To the next slide, please. So this is just giving a sense of the ecosystem in which our innovation hub sat. So you obviously had the hub as the core, but then it had the hub partnerships which you spoke to and the wider system characteristics. And it's really trying to say like how, what are the various levels that you need to be working in the right way to support the accelerated adoption of innovation. And it was really interesting. I think we found that there has been improvements in system working and the conditions that lead to improved adoption of innovation. So I think, this is it's been a real pleasure working with Cambridge and Peterborough on the journey of the Adopting Innovation Programme. And it's really this will be very, very relevant going forward. So I hope without further ado, I'll pass it back to Vicky, who can introduce the next individuals. I think that's me.
Thank you so much, Candida. So that hopefully gives you a little bit of context, and you'll see evaluation referenced at the bottom of one of those slides as well. So we'll try and get that into the resources that we share with you afterwards. So I would like to now hand over to Helen to start the journey that the team are going to take you on today. Helen, over to you.
Lovely, thank you. And we should start really by thanking a few people, I think, including Candida and the Health Foundation for selecting us as one of the 4 hubs, because I remember, when we went through the process, there was a lot of interest, a lot of excitement around it, and we were just so delighted to be selected. So thank you. And also thank you to the Innovation Unit and RAND, who provided so much support throughout the journey as the kind of strategic partner and evaluator. And they were, I learned personally a lot from them. And then I also just wanted to give a shout out to the original folks that were involved in the bid that moved on to other roles as well and are doing amazing other things. So Ewan, who was obviously mentioned in the previous slide, Kathy, Patrick, Adam, Ellen, their work was really pivotal in taking us as far as we got. So just wanted to give them a shout out. Okay, right. If I could move on to the next slide, please, Maddie. Brilliant. Right, so this is just a scene setter really to show you the breadth of people that we partnered with on this programme, and we were so delighted to be able to convene so many people together on it, because we definitely had the ambition right from the get-go that this was going to be a systems hub. It wasn't going to be limited to one organisation. We wanted to really sort of push our understanding and learn how to do this in a more systematic way, bearing in mind that those ICSs and ICBs were emerging. So as you can see, a real breadth of assets all coming together, including our wonderful East of England Citizens Senate, so patient representation right at the heart of this. And yeah, it signalled a real step change. And I suppose one of my very early observations is that when we did convene these people together, it was the first time they'd come together a lot of the time. So it really was a kind of, a real step change in collaboration and partnership working, and people got to build more relationships through this programme. So that was one of the major successes, I think, out of the programme. On to the next slide then, please, lovely. Excellent. Right, so this was the model that we designed. It was based very much on the spread challenge that Candida referred to. So we looked at that and then we thought, okay, how do we bring this to life from that learning? What do we actually need? What are the enablers? So as you can see, 8 enablers. I'll talk you through them really briefly. Obviously, we recognise that nothing will work unless you've got some people that are dedicated to pushing the momentum. So we had a team who I think were two and a half full-time equivalents, so not a massive team, but enough to really kind of galvanize people and bring people and convene people together. Secondly, citizen co-production. As I say, it was really, really front of what we were doing. We wanted to do something very differently and make sure that citizens were really guiding us and aligning us around the needs of the community. So that became a really, really important enabler and something that has continued into the future as one of the major successes, I think, of this programme. Thirdly, we recognise that innovation is often seen as a kind of like an exclusive little group that a little team does within an organisation or within a system, and we didn't want that. And we thought the only way that we were going to be able to get everybody involved was to have a really, really kind of strong communication campaign to spread the word and to really kind of get the energy going and people engaged. So again, that was a really key enabler for us. Then we had hub link workers as well, which was a term we coined, which was basically trying to identify within each of our lovely partnership organisations a person, maybe 0.2 FTE a week, that would just be somebody that we could tap into as an anchor within each of the organisations to help us to navigate when we needed to bring people in. And again, that had success in some areas, not so successful in others, but it basically added capacity then to the very small coordinating team, and again was felt to be an important part of it. Then we had something called the Innovation Culture Club, which was again about trying to put training and learning and development really at the heart of what we were doing, so that we would be continuously learning alongside the community of our workforce. So that was where we kind of brought people together and really sort of stimulated conversation and learning and knowledge transfer. Then the next one was around the leadership concordat. So there was a recognition really that leadership, although a leadership can't enforce this type of approach, it's really important to make sure that we've got the mandate from the leaders to say, you can do this, you can take a risk or two, we're behind you. And we felt that was a really important thing to have in place. So we actually had a physical concordat that each of the leaders of the organisation signed up to, and we could waive if need be, if people started to drift away or get disengaged. So that was a really important, and obviously it didn't cost us anything to do that. That was just about getting people sign up. So that was really great. Then we had something called the Adopters Network, which was trying to build on the existing assets and experiences that we had within the system. So identifying those people who had already attempted to adopt innovation or who had developed their own innovation, so clinical entrepreneurs and the like, who could act as kind of a source of support to people that were then implementing through the adoption hub. So again, it was kind of just building on the existing asset and giving recognition to the people that had already done a lot of the work in the background. And then finally, evaluation. So we wanted to have evaluation at the real heart of what we were doing, to make sure, because again, that's often the barrier that you face right at the end when people say, oh, it's well and good, you've tested this, but where's the evaluation? Where's the real world evaluation? So we convened many of the region's most brilliant academics to give their time for free, I think the majority of the time, to help to guide and to steer us to make sure that the evidence that we were developing of impact was authoritative and would be compelling. So that was the structure of the hub. Next slide, please, Maddie. And then these are the things that we noticed were the main outputs of the hub that we hadn't necessarily anticipated, shall I say. So bid development became a real product of the hub's work. I think overall they managed to secure about £390,000 worth of investment from different sources in collaboration with other partners, but no insignificant amount of money. And something that we hadn't anticipated, but they filled that gap because there wasn't anybody in the system that was working at that level to be able to convene people. So bid development. They also really drove co-design, particularly with patients, but also with the workforce as well. And that became a really valued asset by the system as well, because at the time there wasn't anyone currently doing that piece. So that was really effective. Then obviously we had a great deal of upskilling that came through the work of the hub. So the kind of training sessions that we ran, some of it was online, some of it was face-to-face, but there was the evaluation that we commissioned independently locally demonstrated that there was a real upskilling that was supported through the hub. And then obviously, as I touched on right at the start, system convening, I think that was one of the major kind of wins for us as a hub, that we, as I say, were able to convene people in a different way. So people were able to get something out of it, new contacts, new networks. And that really became the collateral and the currency, if you like, of the hub, that we knew where people were, we knew where programs were happening. And that's obviously the lifeblood of an innovation ecosystem. So that was really important. I think the hub were also able to support the system around direction setting. So they were obviously doing lots of work in lots of different parts of the system and were able to then bring to the fore thematic issues that needed addressing. And then finally, the hub and the partners aligned around the hub were able to also support that, the trickiest of work that Candida referred to, the implementation of innovation. So it really kind of, I think, working in the Health Innovation Network help to promote our role and to support greater awareness within that system of what we could do, particularly as a Health Innovation Network, to support implementation on the ground. Lovely. And then these are just a few of my reflections. I won't go into lots of detail, but effectively, I suppose what I felt is it became very clear that the hub needed to be very adaptive and take an adaptive leadership stance. So depending on what the policy was coming at us at that precise moment in time, being able to, it goes on to the next point, being able to pivot to accommodate whatever was coming at us, so that the hub really did become a servant of the system rather than trying to pull the system in a particular way. And I think that's what's given it the sustainability and the longevity that it now has. Also, as I say, the social capital was the major win for us. For the first time, we were able to start understanding where the key assets were, and then introducing people and really kind of building that social capital. Then obviously patient and public co-production. I won't labour the point because I know we're going to have a chat about that in a minute, but really integral and a beautiful example of where this really comes into its own and really helps to steer a system towards the needs of its communities. Communication was a problem. I think the reflection is it is always going to be really difficult to communicate and keep people engaged across a massive system like an ICS. And that that couldn't be underestimated. It's a job in itself to keep people engaged and informed. And of all of the enablers of the project, I think our communication campaign was the one that was the trickiest to pull off. And I'm not entirely convinced we did, because in an ideal world, you'd have had a whole communication team working there, promoting it constantly. But of course, that wasn't possible. Realistic in terms of expectations, again, that was a major learner. This is often a bolt-on to somebody's job, so just being able to be really understanding that not everybody will be able to engage all the time, but being okay with that and drawing on other people to fill gaps. The other thing for me, as you would have heard from the roll call at the start, we lost a lot of people along the way into different roles, as is always the case within the NHS. So what was really important learning was that you couldn't rely on an individual. It couldn't be built around one individual. This has to be something that builds slowly with consensus from all of the players all of the time, because otherwise what you end up with is if that person then drops off the radar, then it falls apart. So it's really important that when you do create these types of hubs, that it's a system and a team sport and not an individual reliant one. Also, love the problem. I've nicked that from our counterparts in Dorset, I think, who said that that was one of their major learnings, and it was ours too, really, that if you were going to, you know, when you're working on a project as a system, you need to know your problem inside and out before you try looking for solutions, so that everybody is absolutely thoroughly convinced that the problem that you're going to target your resources towards is the right one. So really, really understand it, because the temptation is, well, I've got a solution here, I've got a solution there that will work. And of course, you know, you need to really, really understand everything about the problem before you start moving to solution stage. So that was a big learn for us. And then just the last 2 points on business processes. For us, the culture within Cambridge and Peterborough, I think it's fair to say we're very evidence-led, we're systematic, we like a process. So what we have created, I think, and what will always be the legacy of this piece of work, are the processes that mean that when we make decisions together, and we make decisions in a systematic way, which, you know, can stand up to scrutiny. So business processes for us became really, really important. And then finally, the culture and the narrative. So again, I touched on it then, but understanding what the culture is of your ecosystem. You know, are they hearts-led? Are they brain-led? Are they, and then playing and using that knowledge of your culture to then be able to encourage people to collaborate and to get on board. So it's a live thing, an ecosystem for innovation. So you have to, you know, you have to really appreciate and respect the fact that, you know, it is about, you know, localizing things and understanding what are the drivers, what are the things that are relevant to that system, because there's a lot of things that systems can concentrate on, and making your thing the priority means that you have to really understand what their motivations are. So that was a big learning for me. And I think that was it, wasn't it, Maddie? Yep, right. I'm going to hand over now to my fabulous colleague, Louis Camphor, who is the Deputy CEO at Cambridge and Peterborough ICS, and is also the Managing Director for the Strategic Commissioning Unit. And he is going to talk us through the next journey into the ICB.
Thank you, Helen. And I think that last bit that you talked about is so incredibly important, because I think the key learning for us, as you say, is, you know, having the right people, having our system partners front of the table, but being so purposeful and intentional about what we want to move forward, given that we're all operating in environments where we are very resource constrained, and actually we want to continue to offer a reasonably consistent offer to patients, and we don't want to fragment, and we want to be making sure that we use our resources effectively. So I think a nice segue actually into what we're just about to talk about. So I kind of worked in CCGs as kind of part of my career, and before that in the private sector. But if I had to kind of pick one thing that I thought actually CCGs back in the day should have done better on reflection, it is this kind of notion that we spend quite a lot of time in 12-month planning cycles, 12-month recovery, very short-term thinking, and very much trying to balance financially, you know, deliver all the performance targets. And if and look, this may not be true for all CCGs, that may just be the one that I worked for, but I think when we set up our ICB in Cambridgeshire and Peterborough, we recognized that we needed to be much better informed about the clinical and financial risks that are coming at us as a health service and a care service, and the kind of things that we need to do to really intervene and change how we provide care and how we intervene with our population in different ways. And so we created a strategic commissioning unit, and the kind of the components on the slide basically just sets out the kind of key things that we try to achieve by setting this up. So we wanted to be much more informed about the population, as I said, the kind of key drivers of financial and clinical risk. When we are looking at solutions, we wanted to be much more evidence-driven about those solutions that we're implementing, and I'll talk a little bit about the kind of thing that we're planning later on. We wanted to focus on outcomes, because I think a lot of what we do in health is activity-driven, not necessarily outcomes-driven, and we recognize that actually the way that we could pull our ICS and not just the ICB together was around a set of outcomes, which again, I'll talk through a little bit, but needs to be very much based in our kind of evidence that we've come up with. We recognize that resource allocation is an enormous lever And that's not, you know, in the next 6 months. If we think sort of 5-10 year time frame, and the kind of shifts that we need to create in order to make healthcare sustainable, resource allocation is going to be fundamental to that. And we wanted to be much more purposeful about the planning for that. And there are some things that we are delivering as a unit as kind of proof of concepts. And we'll hear an example on kind of CVD later on. So hopefully that gives a bit of context in terms of what we are trying to do. What I'll just say is my background is kind of CFO, and I know we talk a lot about aging populations. I know we talk a lot about, you know, I've heard that line probably 1,000 times. I have never actually recognized or realized how bad this is going to get and how quickly in terms of our aging population, because one, our lifestyles are completely different. Two, our demographic in the country is changing at such a pace that we think today, you know, post-COVID world, lots of waiting lists is bad. It's going to get fundamentally worse if we don't do something radically different in health and care. And to put a number on it, we've been doing quite a lot of work in our ICB and with our regional team to support our new hospital programs. Just for our ICB, by 2040, we think we will need 900 extra hospital beds. I will need 2 more hospitals just to cope with the demand that's going to come. That number is probably about 400 by 2030, 400 extra hospital beds just for my ICB. If you look across our kind of east region, that's about 3,500 extra hospital beds, which we won't have. And actually, unless we have the models of care that will either prevent ill health or is going to significantly shift it into very different models of care, we won't be sustainable as a health and care system. And I think hopefully helpful just to kind of put some context on, and this is what keeps me awake at night now, recognizing we need to keep grip on today, you know, financial performance, operational performance, but what's coming is frankly scary. But I also think there's massive opportunities for us to do things differently. If we go to the next slide, then, so this, I mean, isn't the clearest slide, but this is the work we've done with our kind of patients, but also with our kind of entire system, and kind of all our partners to work out what are the key things that we should be aiming for to kind of try to shift the things that I've just discussed. There's a lot of evidence that sits behind this kind of high-level outcomes framework. You know, we looked at burden of disease, we looked at our population, we looked at a lot of the demand and the clinical and financial risk, as I say. But you'll see essentially, you know, we're talking about wider determinants of health here. So absolutely an absolute area for some of our local authorities and our district councils, etc., to play in. There's a lot on kind of behavioral science, which we need to change. There are a number of kind of disease-specific areas that we think actually there is a significant amount of reversible or modifiable risk factors that sits within that. And if we target those, we can actually change our demand profile quite significantly. And all of those, if I had to summarize it, and one of our clinical leads always say this, is aimed at trying to push adverse kind of health events back in people's lives as far as you can. You know, so we want them to hit, you know, when they're over 75 or frankly over 80. We want the healthiest over 65s if we can get there, because that's the thing that's going to be the game changer for our population, and all of these things will play into it. If we move to the next slide, please. So we've done a lot of kind of thinking about, look, what are the key fundamental shifts that we can make as a system and as a region to kind of live within our means, if you like, over the next sort of 5, 10, 15 years. And I'll just step through this quite quickly because there's a lot of detail behind these. But we believe that we are not maximizing our kind of digital offer to patients at the moment. And if I'll just stop myself there for a second and just say this up front, the idea behind this model is we need to offer at scale solutions in a very efficient way for the parts of our population that are happy to respond to that and happy to work with us on that basis. We absolutely recognize that for the people who don't, we need a very personalized, quite often place-based or neighborhood team level kind of interventions. But we also recognize that with our limited resources, we can't offer that to all our patients, and quite a lot of our population is quite happy to receive interventions in different ways. And when I talk about digital enablement, for example, the first thing people say to me, but not everyone is digital enabled, and that is absolutely true. But a lot of people are. And so we need to do, for us, it's not an or, it's an and. So everything we're doing needs to be at scale, very efficient, but then also very localized and personalized approach. And again, my colleague Simon will talk about some of that a bit later on. So on digital enablement, we recognize that our offer at the moment is very inconsistent. It's fragmented for our population. Lots of our practices are using digital tools. They don't use them the same. The ability for patients to kind of access is really, really different depending on where you live and your local practice. We also recognize that as part of our digital offer, there's lots that we can do to help patients optimize and manage their conditions. We've heard through our citizen group that you'll hear about a little bit later on, from some of our communities with CVD, for example, with a hypertension diagnosis. We don't know how to manage this condition because all the advice that you're giving us are based on a Western diet, for example. There's a really fundamental things that people can help optimize their conditions, but actually we can give them so much more tailored advice and information about how to manage. So the digital offer is about access. It is about information, and it is about options and optimization for certain conditions. And we are exploring how we can do that, linking in with the NHS app. But we think that, and very much linking with the NHS development and the pathway there, but we think there's a lot more that we can do with patients and for patients on digital. And in its most extreme, you can open up so much more for patients in terms of the options for accessing things like repeat prescriptions or lots of different things that we are actually just channeling through one avenue at the moment, but actually we could open up. On health optimization, this is the bit that I am probably most excited about, because when you look at our data, we now have the ability to be able to identify individual risks for patients and the reversible risk factors. So we can look across our patient population and say, who are the most highest risk individuals and what is the most impactful thing that we could do for them based on their modifiable and reversible risk factors. And the pilot that Simon will talk about is all about CVD, but actually there is an enormous amount that we could do through this. And we are taking very much an at-scale approach at the moment, but we recognize, and again, the beauty of this is the patients who don't respond to that, we will see that in the data. So I will know exactly who has and who hasn't been optimized based on the interventions that we're offering. We're doing it very much with our GP practices. We're giving them a number of options about whether they work with us and we do everything for them, but they prescribe, or whether actually they want to do some of the work where we segment kind of centrally. And I don't want to go too much into this because, as I said, Simon will talk about it, but there is an enormous amount of invisible risk sitting in our population that will crystallize in a hospital in the next 6 months, 12 months, 18 months that we are ignoring at the moment. And someone asked me, is the NHS too risk adverse? And I said, no, we're not, because we're ignoring about 70% of our risk sitting out there in the population because we're only dealing with the people who are presenting in an ambulance or in A&E today. And I think that's fundamentally, for me, this pillar, as we call it, is a game changer for how we can do health and care going forward. And I think it will be the thing that fundamentally changes our demand profile, especially if we look at that kind of aging population. As part of this, also we recognize that kind of high utilization individuals is quite is an area for us that we need to focus on, because again, multiple partners in our system will be dealing with the same parts of our population, the same families, the same individuals quite a lot. And just to give you an example, we've got 250 patients in our system who've used NHS services or had contacts with NHS services 18,000 times in 6 months. And that excludes GP practices. So those are the kind of things that we are thinking, actually, there is someone in crisis here, something isn't working. They are being handed off between one service to the other one, and they are not being de-escalated and optimized in the way that we can. So another area is just kind of focusing on those high utilization. I'll speed up, sorry, I'm conscious I'm taking too much time. Acute illness is, again, thinking about the technology and the innovation that we've got available, how we wrap around care and predict, crisis and wrap around care much quicker, so that we fundamentally avoid patients having to go to A&E as the first and the last resort in all cases, because I think there is an enormous amount that we can do there. I can happily go into more detail. And then the last 2 years of life, we've had a lot of feedback on the wording there, which I think people are asking us to change. But I think that's recognizing that 30% of our bed base in hospitals are people who are in the last kind of year of life, and for a big number, it won't be where they want to be, and it could be avoidable. We absolutely recognize that for some individuals it won't be avoidable, but actually with, again, if you think about innovation and technology and what's available and how we could support patients at home, there is an enormous amount that we could do differently with this cohort that could lead to a much more sustainable picture. I'm not sure if I'm now done or if there's another slide, I can't remember. No, that's done. So I think just wanted to say, as part of all of that work, we recognize that innovation is fundamental. And, you know, I should have said on the resources and the allocation of resources, we're doing a lot of health economics work as well. But the point I was going to make is we now understand far more the kind of intent and the things that we want to try and get done. We can be far more intentional about how we use innovation to get that done. We want to make sure that our patients have a consistent offer. And because we are trying to create such a big shift in care, how we evaluate and change all the time is going to be fundamental. And we're working very closely with kind of Health Innovation East, with ourselves and with some of our partners at Cambridge University, to create a health economics and evaluation function that also can support that. And the other thing that Emma will no doubt refer is we're also trying to be much more purposeful about the selection of innovation to make sure that we're going for the things that actually will make the biggest difference and will help us kind of deliver this left shift. So I should have blocked a bit more on the innovation, but innovation for me is an enormous enabler for all of that to happen, but we need to do it in the right way. I'll stop there. Thank you.
Thank you, Louis. And we've got just a couple of minutes, and I know there were a couple of questions in the chat, so I'm just going to pull those out for the team. There was one from Karina about how can HEIs adjust to support innovation in this adaptive way, in the context that as staff often being judged on funding applications with slow turnaround times. So I don't know if that's Helen or Louis or someone else want to have a go at answering that question.
I'm really sorry, would you mind just repeating the question? Apologies, I'm just trying to find it.
Yeah, so how can HEIs adjust to support innovation in this adaptive way? And that's in the context of as staff often being judged on funding applications with slow turnaround times.
Really tricky, isn't it? I think we all struggle with it. I think it's the work that we were doing that enabled us to adapt, I suppose, is where we had opportunities coming to us at the right time that seemed that we could pivot things towards. So I suppose it's about being on the lookout constantly for new opportunities, and you know, just that kind of lateral thinking of, oh, we could actually shoehorn that into that. You know, so when I talked earlier about the 390k, they were all kind of opportunities to test different things with external funding that kind of came midway through that we hadn't anticipated, but came at just that right time. And having the relationships in place with the key players to know what was the best use of that potential inward investment. So I think what higher education institutions probably need to do is just make sure they're around that table with the decision makers at the right time. I know it's really difficult because you know, lots of demand on time, but yeah.
I was just going to add, I think, Ellen, we are kind of talking about it later, but what we're trying to kind of create is an environment where we are very clear on making decisions about innovation, and almost in a way that, you know, you create a pipeline of things that we are happy with. And I often reflect, as a CFO, if someone comes to you in July and say, I want £100,000 for this innovation, it's fantastic, and all of you go, well, that's great, but how on earth am I going to fund it? I think what we're trying to create is a system where we've got approved innovation that we know completely aligned to all the things I just said, but actually we can give people notice on to say, when we hit the 25-26 planning round, these are the 5-6 big innovations we want to go for as a system. And we are much more purposeful again about how we do that, but actually to almost allow our colleagues that are looking after the finances, etc., to have the best chance to support us. Because I think And I just say that the bits of funding is really helpful that comes into systems, but actually I think what we need to do is shift the resources that we have. We're sitting on billions of pounds that we're investing, but probably in the most kind of inefficient way. And when people are tipping into crisis, some of it is new bits of funding, and some of it is actually how we think about using the funding that we've got at the moment in different ways.
Thank you, Helen and Louis. Emma, you've got your hand up. I don't know if you wanted to add something or respond.
I was just going to be quick. So we work with Anglo-Ruskin Uni, for example, as part of the innovation working group, and we've helped align some of the work that they're doing with opportunities such as with SBRI grants and the earlier stage innovation, working with Health Innovation East. So I think touching on that collaboration again, when you get to work together, it's not necessarily the ICB is fundamental, but actually convening them has allowed those opportunities across all partners to be realised. I think that's a good example.
Thanks, Emma. And there's some of the more recent questions I think we might be able to come to after Emma's next bit. There was just one clarification bit, Candida. I just wondered if you could add just how long have the innovation hubs been running and how widely are they spreading when we talk about spreading innovation? I don't know if that's something you can answer briefly.
No, so we started the program, I think it was in 2021, so it's around a good 2 years, and it's been really interesting to see their progress. And in terms of the stretch and how far they're spreading, they've been spreading their locality. So across the ICS patch was a really good unit of care, reach. So I think that those are the two areas. I hope that answers the question.
That's great, thank you. And Natalie, I'm noting your question, really interesting. I think that's more not going to be so brief to answer, so I think we might come to that maybe after we've heard from Emma and Val and Sophia. So Emma, over to you.
Thank you. Maddie, are you able to go on to the next slide, please? So I think as part of the move from the innovation hub sitting at provider moving into the ICB, we wanted to be clear on what we're trying to achieve and our vision for innovation, which I don't think changed across the hub to the ICB, but we do want to be able to adopt innovation more readily and to achieve some of the goals that Louis has set out and become an investable proposition for industry. There's a lot of resources out there and and expertise that we don't have and we shouldn't have, but we need to be able to leverage them in the future as we move forward and shift in the models of care that we need to do. Just touch on, we need to really work together and collaboratively to share resources across, and the capability that we've got on our doorstep is massive. And I continue to find new partners and all the time in just Cambridgeshire and Peterborough alone. So yeah, as Helen's mentioned, collaboration is key. Next slide, please. And as we moved over from the hub through the adopters network and lots of engagement, identified several barriers to innovation. And what we wanted to do was make sure that the way we set up our innovation processes in the ICB and where we can leverage what the ICB role is to really address some of these. So we know that we needed dedicated resources, and as such, because of recruitment freezes and capacity that we have, we were able to work with our partners in Health Innovation East to build more of a dedicated team to support the adoption of innovation. The other thing that we've done is build a large network. So we have over 10 organisations represented in that network at the moment, and it continues to build. And that's really helped us in pulling in resources as and when we need and learn from each other. We know we've got a complex ecosystem, and for an internal innovator to an external innovator, it's really difficult to understand how to work through our processes. So we know we need to be more transparent, and through Cambridge University Health Partners, they've been developing innovation landing zones across our system, and we'll be touching on those later. We've also developed a specific CVD landing zone, and Simon will talk about that infrastructure and how innovation can readily be plugged into that moving forward. As Louis and Helen have both said, we are have a massive emphasis on making evidence-based decisions, and we have been using our health economic function and tools to develop from the Institute for Manufacturing, who developed the criteria with the Innovation Hub. We've been able to move that into this health economic function, and we're able to have a prioritization of innovation based on projected impact across our priority areas. And we will share those resources with you afterwards. We'll share the tool as well, so you can see, and the criteria, and any questions on that, please come back to me. We know that there was issues with trying to bring in interventions in certain areas where the budget holder wasn't necessarily the person benefiting from this, and therefore as a system approach, we wanted to build mechanisms where we could have an opportunity to invest in these interventions and innovations that would have a greater impact for the whole, that sat outside of organisational boundaries. So the next slide, I'm going to be talking about the governance that we've put in place to try and achieve that. We were aware that we had a lot of pilots going on that didn't necessarily have a sustainability plan moving forward, or where we'd go next. So as Louis already mentioned, we're working with Health Innovation East and the ARC and Cambridge University to build a health economics and evaluation function, so we can more quickly evidence whether things are working, and we can make commissioning or decommissioning decisions based on that information. Next slide, please. So as already mentioned, the Citizen Innovation Group was a massive value proposition for the Innovation Hub, and has continued to be the core and centre of everything we're doing in the ICB. They've been involved in the decision-making process for bringing in innovation, the reviewing process. They have, and I won't try and take too much time on this because Val and Sophia will talk to you about this on next slide, but they have judged challenge prizes, they've helped internal innovators progress their development, they've shaped implementation projects, and they've supported external innovators on developing their offering. So a fundamental capability that we've got, and they've been brilliant in everything that we've put forward. So they're also involved in the Innovation Working Group, which, as I mentioned, is a network of over 10 organisations at the moment and continue to develop. In this network, we've been sharing learning. We're trying to build a work programme where we can start helping each other out. We're all trying to tackle similar things, so what can we do together? The key function of this as well is to identify the innovations and review the innovations and recommend them to the System Innovation Panel. And this goes back to trying to prevent those budget silos, stopping us investing in innovation, which is of great need to our population. The System Innovation Panel then, as Louis sort of mentioned, will make recommendations, and this will form our innovation pipeline, which will be able to pivot towards any funding opportunities that come available, or fits into financial planning as per normal. So we're got the second panel this tomorrow, and I think it's interesting actually, the innovation that's going there and who's gone through this process originally was piloted in the system, but because it needed to shift its implementation approach, then became almost a system-wide innovation and therefore wasn't continued. So I think yes, this is an interesting process, and we will continue to learn from what we're doing and adapt to try and overcome those barriers that have already been identified. So I think I'm now handing over to the wonderful Val and Sophia, please.
Thanks, Emma. it's really quite inspiring to hear this story that's been going on in our own system over the years, and you know, we've completely realised the challenge ahead of us, but looking back, we've come so far. So I'm just going to say a few words to bring to life, really, through some examples how the citizen group has participated in this all along. I was actually put my hand up as part of the Health Watch in the area to join in the bid process back in 2020, 2021 to do that, and then I disappeared off the scene whilst it was determined whether we'd won and what we'd do, and appointing team members, and a group of citizens were recruited by the team members, and they created a role job description for a leader amongst them to link with the team and be the citizen role lead person, and I managed to secure that post in October 2022. Savia, who's joining in a moment, was one of the original members, so there's some real continuity there in our stories. So we started with more than a dozen citizens, very active in doing that guiding and aligning that was spoken earlier about. Yes, of course, go for that, helping that bid be successful, or do this, that and the other, and adding our sort of experience along the way. Whittled down to about 5 active members recently. I think the transition from the hub pilot to being based in an ICS has taken its toll in several respects. So we've limped through that process, and now just recruited, and another half dozen are about to join us very shortly. So we evolve as a group, and we want to remember our history and what's been achieved, but also be agile for the new challenges. So the way we anchor our business is to have a monthly meeting for an hour, and to be very sympathetic and repeat that meeting on occasion if necessary, if people can't go during the day, work hours, all that type of thing. But we have managed to get, have that regular contact with each other, and at the time do our business side, but on the other time kind of collapse into workshops where we've had some really exciting presenters on technology and other things, you know, coming to sort of pick our brains in more detail about various things. So it's been very interesting. We also stop to pause every now and again and evaluate our own interests, why we're here, what we bring, the perspectives we've got, look back at all our minutes, and we've generated a list of about 12 questions that we've persistently asked, which almost become a tool for thinking about the public on some of these things, from the very basic, have you thought of asking patients what they think about this, to, you know, more innuendos about, if you get carer support engaged, will that help the activation of the target group you really want to go for, etc., and things like that. So I think we've been systematic with our methods and anchoring what we do against our experience, bringing that forward. Just give you a few examples. We, in the early days, one of the innovators from one of the trusts wanted to develop a website to support people with relational and emotional disorders, which are also known as personality disorders, self-help, learn, manage, get inspiration around, you know, their own life and its challenges through an online resource. And I will mention this as well, but for me, we recruited 3 groups, focus groups, where the innovator was an observer, and we worked with those people in a really interesting way to get very deep down into the feedback around this approach, and played that back into the organisation, and that has we recently had that topic revisited, and great progress is made, and the educational initiative is ongoing from that. A year after we received the funding for the hub, we organised the showcase event. The team were key to that. The citizen group were a really important part of ensuring that the public were at the heart of that event, and to share what we've done there. So we consider that to be really, really successful. Hitting the button about the culture and alignment, I think, that was mentioned earlier, is really important. yes, we judged the Innovation Health Inequalities prizes, and we designed our own method of doing that so that all the group would have an input, but one person would be represented on the judging panel. It's eternally supporting each other to get the best out of us as a group to contribute to whatever was needed in the system there. And then, well, I can't say enough about the interest of having presenters come to us as a group, and whether they be from PocDoc or Luminova, or even thinking about dementia and AI. It's really stimulating. And again, we've developed a system. It's not just us as a small group of people giving our initial feedback, but we've gone and thought about it. We suggest other people to talk to, and trying to link it out into a broader initiative. So we check at the end of every meeting between ourselves, have we been listened to? Do you feel you've been listened to? 1 to 10, score 9.2 so far accumulated. And how confident are you that your input will make a difference? 9 out of 10 cumulative on there. So yes, I think the importance of co-production, the title of this session, I think we champion that, and would say that it is a key culture within this hub. I definitely believe that. Have we made an impact? I think that's for others to judge. And as we go through, we're always keen on feedback about whether what we've said has been useful to the people who are going to be taking it forward. So Sophia, one of our earliest members, please do come in.
Hi, well, good morning, everyone. As Val mentioned, I've been with the group since the start. And my main reason for joining was that I've always had an interest in healthcare. My mother was a nurse and my father was a doctor. And having the chance to become involved with looking at how it can be improved through innovation was something that really appealed. Thanks to my experience with the Alzheimer's Society, the committees I attend at North West Anglia Foundation Trust, and my role in my local GP's patient forum, I hope I'm able to contribute in a meaningful way. As I like to joke, I have enough medical knowledge to ask the awkward questions. So one of the projects we've been involved with that stands out was about an app that could be used to support people with borderline personality disorder, which Val mentioned earlier. The clinicians had obviously spent a long time thinking about the disorder, and the support offered was varied and detailed. But that was the problem. There was too much information. When I ran it past my daughter, who has a diagnosis of autism and also has a friend with BPD, she said that she wouldn't have been able to get past the first page, particularly if she was in crisis. This is where the Innovation Citizen Group can be most helpful. We can remind clinicians that the patient should be at the centre of care and give an insight as to how support should be given. So one of the things I was asked is, what could be better? There's an awful lot out there. I had to think hard, and this might sound a little bit trivial, but one thing I have found is that the transition to the ICB has been rather complicated, and I'm still not quite sure where we fit. One of the niggles has been about remuneration, and although this is not the main reason for being part of the group, it is a form of recognition that is easily identifiable, and we do appreciate it. As yet, I still haven't received any payments since March this year, despite Emma's efforts. As I said, it's not the most important reason for being part of the group, but Christmas is fast approaching and there are presents to be bought. So I hope I've been able to give you a little bit of an insight into what it's actually like to be part of the group. Thank you.
And I just think that the transition has lost us momentum, I think, in terms of adapting and finding new team members, not just the citizen group, the administration, some lost documents, lost learning, lost contacts with citizens, but also things like, as Fire's mentioned, the sort of the valuing the time and the efforts that people are putting into this work. So that's us finished. Thank you very much.
Thank you, Val and Sophia. Really appreciated that input and bringing the Citizen Innovation Group experience to life. I'm going to invite Louis in briefly. I know we said at the beginning we were going to go for a break at 11:10. I'm keen that we come to Natalie's question as well, because it's so relevant to what's just been discussed. In particular, one of the challenge prizes that was mentioned was directly relevant to what Natalie's mentioned. So we're going to go for a break in 5 minutes, and I'm going to adjust the time later just to let you know. Louis, do you want to come in before I re-ask Natalie's question?
So I was going to try and attempt to answer Natalie's question, if that's okay.
Yeah, of course.
And I think it's really important that when Simon does his presentation, that he will touch on this as well, because it's something that we're very, very conscious of as we're implementing the new care model, or the left shift that we kind of talked about. And it's something that, as we are doing evaluation almost live, as we kind of implement changes, it's something that we're keeping a very, very, very close eye on. And some of the data that we are going through with the pilot project that Simon is talking about is specifically looking at what is the impact on health inequalities. On the other side of that, I think it's really important to say that when we go through the kind of, the unoptimized risk or the reversible risk sitting out in the population, it wouldn't surprise, I think, anyone on the call that it is the risk is much larger in our more deprived areas, and actually there is much more reversible risk sitting there that is not optimized. And I can probably go through 20 examples of where we are seeing things like, for example, cancer diagnosis, in our more deprived areas happening in an emergency department or through an emergency admission rather than a kind of a planned. So many things that kind of plays into that. So I just wanted to say that, the reason we're starting with CVD, for example, the reason that CVD is on our outcomes framework is because we know that's one of the biggest drivers of mortality differences between, in under 75. So seeing a 10-year life expectancy difference between our most deprived and our least deprived in our system. CVD is one of the key drivers of that, and specifically the under 75 mortality. But I also believe that actually we need to go at scale and really try and optimize those risks. But as I said earlier, the beauty of those sorts of approaches are that we can see who has not been optimized and who needs a very individualized approach, integrated neighborhood team, or a place-based intervention in a very different way. I'll also just say this, with the technology that we've got available now, we are able to, the point that Val just made, if someone works a shift or they are unable to adhere to an appointment when it suits us, because quite often we offer one appointment, and if someone can't show up, that's it. The beauty of this approach is also with the remote monitoring capabilities we've got now, we can send something to someone's house, for example, and Simon will talk a little bit about that. So there's different ways of getting a population to engage with healthcare that suits their needs and fits around their life in a different way to what I think we've historically done. So I haven't answered the whole question, but hopefully that's an attempt to just kind of say this is not at all forgotten. I should have probably said that much more clearly in the presentation as well.
Thank you, Louis. We have got one other question in the chat that in the next 2 minutes, if anybody's got anything, anybody from the team's got anything they want to add on that, the question about what the solutions might be around making it easier to pay citizens properly and on time. Is there anything on that anybody wants to add?
I think I can say just make it simpler. I think when I had to fill in yet another load of forms and I was actually asked to prove my British citizenship, I think that's when I lost it. But I can understand the reasoning behind it, but yeah, it needs to be simpler.
Thank you, Sophia. Helen, did you want to come in as well on that before we get to the break?
Just to say, I had a meeting last week where all the health innovation networks have come together to discuss this very issue, because there is such variation. There are kind of tax implications and things like that. And if you're hosted by a trust, it makes it more complicated, you know, and you don't want to step into employee relationships. So it is difficult. But actually at Health Innovation East, we have managed to navigate it for a couple of years. So I will offer that to Louis and the team if that's helpful, as a facility that we could potentially offer to make it a bit simpler. But yeah, no, it is a problem, Sophia, and I do apologize if that's been your experience, but it's nothing we can't solve.
That's great. That sounds really helpful. Thank you, Helen. Okay, we're going to go for a break now. I do want to give you your 10 minutes, so we're going to come back at 11:30 and we will. Hey, welcome back, everybody. Hope you had a good break. We are going to get going again because we've still got a few more presentations for you, and we want to give you some time in discussion rooms as well. So I am now going to hand over to Araminta and I think Emily as well to lead us into the next section. Araminta, can I hand over to you?
Yeah, of course. Thank you very much, Vicky. And it's been great to hear all the presentations from partners in the ecosystem. I thought I might just begin by describing who or what Cambridge University Health Partners is. So we are an academic health science centre based in Cambridge. So we bring together the two universities in Cambridge, which is Anglia Ruskin University and then the University of Cambridge, with the 3 NHS trusts who also have a footprint in Cambridge. And broadly speaking, we get involved in the life sciences strategy for the region with a particular focus on supporting innovation right the way through from the earliest research stages through to adoption and hopefully spread. Next slide, please. So I'm hoping what's been coming across from all the presentations so far is that we're working very hard as a system to adopt a sort of 3 musketeers approach. So all for one, one for all. And this is sort of vaguely how we are trying to divide ourselves, thinking about the functions of all the different organisations. So it's been great to hear from Helen around Health Innovation East and from Emma and Louis around the ICS and how the Adopting Innovation Hub, which was where we really started to think through some of the best practice for innovation in the system and develop the methodology, and how that has now been sustained within the ICS. So some of the work that we've been doing has been particularly focused around how we support our partners with their innovation journey, and particularly linking to the strategy of the organisations. And one of the particular pieces of work that I'll go into is what we have termed innovation landing zones. And so these are effectively functions within our trust partners, our NHS trust partners, which would have the capacity and the capability to support innovation. And that could be innovations that are coming from within the trust, so inside out, and how they can support their own innovators, but also to support those innovations that are coming from the ecosystem and want to be tested and trialed within the trust, so outside in. Next slide, please. And the concept of this came from a piece of diagnostic work that we carried out with a whole host of partners and innovators and entrepreneurs, both within our ecosystem, so Cambridgeshire and Peterborough, but then also more widely nationally. And essentially the feedback that came back, which I suspect will not be unique to CMP, was that it was incredibly confusing. They didn't know where to go and they didn't know whose job it was. So basically it was just really difficult to be able to engage with a trust, to be able to think about testing and trialing a product. And as CUHP and our board, we decided that, well, one of our #1 ambitions was to be the place that people would want to come to test and trial products. So how could we support our trusts in this? And so we developed this innovation landing zone approach. And actually, as CUHP, we've been able to pump prime these within our NHS trusts. So we part fund posts within the trusts to start thinking about developing this function. We divided the function into a number of different areas where we want to help the trusts develop their capabilities. And so these are broadly, the first one really being around signalling and decision making. So really making sure that the trust itself has a strong understanding of what it wants from innovation. So what are the particular areas that it needs innovation to try and solve? Some of these are very much likely to be aligned with the overall system challenges, but some of them might be quite trust specific, depending on the type of trust. So for instance, in our patch, we have a cardiorespiratory national specialist hospital. We also have a mental health services and community services trust, as well as a district general hospital. And so all of those actually have slightly different requirements from innovation and where they'd like to signal to the ecosystem that they need some support from innovators. It also thinks about horizon scanning. So what is out there? What's the best innovation to take forward? And how do we provide a front door for the trust so innovators know where to go, whether that's from internal or external? And then how do we link that front door to what is going on in the ICS and the ICB? So is there some portfolio management tool, a portal where we can link all of that together and get more visibility as a system on who is doing what? Then there's the sort of day-to-day management of how we're going to implement an innovation within the trust. So some of this is very much around contracting and commercial. So do we have appropriate terms for IP? Do we all know what they are? Are there draft commercial agreements that we can support our trusts with? So they have, you know, kind of templates of what to do when. And is there a function that can handhold an innovation through all of the different trust functions and processes? So, you know, have they talked to the operational teams? Do they know what data integration might be involved? Have they got the go-ahead from information governance, for instance? There's a big piece, I think, particularly around data integration and availability. So a lot of the innovations that we're looking to take forward might require some sort of interaction or docking into the electronic health record system. And so have we got the capability there to be able to do that? And then also linking into the evaluation and spread, there's a big piece around being able to do the data analysis with appropriate endpoints to be able to show whether your pilot, for instance, has worked and how and when you'd be able to roll off onto something more full scale. And then, of course, I think I've heard this from lots of people, and it was really interesting. It was the topic of the breakout as well this morning, was around that change management. You know, I think we all understand the NHS can be particularly risk averse. So how do you start changing that into a culture where it's actually okay to try things and fail? That's the nature of innovation. And I think there's a big piece around there, around leadership. How do we incentivize staff, and how do we communicate that across what are very big organizations? So I think that change management piece can't be underestimated. And then finally, around evaluation and spread. So are we looking out for the right funding opportunities? So as Louis was saying, you know, do we know what's coming down the track? Are we prepared for those? Have we got some support in place for those applications when they come? And then obviously a really big piece around there, around the evaluation, around the patient and public involvement and engagement, and really great to hear from Val and Sophia earlier as well on that. Next slide, please. Thank you. So one of the ways in which we've approached these innovation landing zones is to effectively get that senior level buy-in at our board to say, okay, this is something that we're all interested in doing collaboratively as 3 NHS trusts in our ecosystem. And we've actually also been working very collaboratively with NWAFT, which is the trust to the north of our patch towards Peterborough. And so we want a collaborative approach. We want to make sure that we are including public and community in that. And so what we've done is to bring it to the board regularly to say, how are people progressing their innovation landing zones, understanding that they might look quite different in some respects in different trusts, but also to share sort of learning by doing. So if we're taking forward, say, 2 new health technology initiatives, what have people found? What are the problems? What's gone well? What hasn't gone so well? Are there things that we can tackle together at board level to be able to support that. And then I'm going to hand over to Emily, because Emily has been the person who has been doing this on the ground with one of our trusts, with Cambridgeshire and Peterborough NHS Foundation Trust. So Emily has been jointly funded through CUHP and CPFT, and then she's going to take us through a little bit about how they have been trying to develop their innovation landing zone. Next slide.
Thank you, Minty. So, as Minty said, CPFT is Cambridgeshire and Peterborough Foundation Trust, which is a mental health and community provider. I get the honour of leading innovation activities at CPFT, and their vision for the Innovation Landing Zone is to be an exemplar site for innovation within the NHS, supporting both creative and entrepreneurial staff to exploit their good ideas across a broad spectrum of innovation, from simple service improvements all the way to the commercial development of new devices to the benefit of patients, staff, and the organisation as a whole. The challenge for the organisation, and has been spoken about previously in previous presentations, is how we translate this quite big aspiration into tangible actions that support the objective. So we have a number of key projects within our Innovation Landing Zone, and the overarching goal is to develop and implement clinical innovation that meets patient and staff needs. So within our enabling projects for the landing zone, we look at scoping the current innovation ecosystem at CPFT and nationally, so understanding opportunities for quick wins and more big ticket items, so thinking about how we plan for the future as well. Providing staff with training and opportunities to develop into clinical entrepreneurs. We speak a lot now about portfolio careers within the NHS, as we want to keep hold of those really good staff members, but our staff want to do different things. So how do we help them develop into entrepreneurs as well? So we're currently doing this through learning opportunities such as innovation clubs and e-learning. Extending the innovation portal. So this may have been mentioned in previous presentations, but it's our industry door to the NHS, and we want to upgrade this, working with the ICB to be able to make this a system-wide innovation portal, which I'll speak a little bit more on the next slide. Development of relationships with the local ecosystem and industry partners. We're really lucky in Cambridge to be surrounded by a large amount of talent and organisations in our region, and CPFT want to build collaborative relationships with these organisations. And really importantly, communicate and publish progress. So, for example, we started to get traction with some adoption projects. So one project that was supported by the Adopting Innovation Hub was the implementation of Minuteful for Wound from a company called Healthy.io. And from that project, CPFT has taken it forward and has had 3 invited peer review publications, which has really given us an opportunity to share best practice and build our reputation in this area. And finally, a strategy that communicates all of this, both to the organisation and beyond. And since working with Cambridgeshire and Peterborough ICB and CUHP on the landing zone concepts, CPFT has become the holder of the region's Insight Award, which is the first mental health trust in the programme. So that's a national programme that supports us to share best practice and develop more innovation adoption within the trust. Next slide, please. So through the overall Innovation Landing Zone work, as a system, we've learned a lot, which has meant that we understand and can refine some of the requirements of an Innovation Landing Zone. So if I just pick up a few key points. So building capabilities is important. We need to utilise skills that we have within the ecosystem, prevent duplication of effort, as everyone is really short on time and resource. We recognise the importance of clinical champions. From my personal experience at CPFT, innovation adoption will not be successful without having a clinical champion driving the project. We need to support adoption projects. So for example, as a system, we're developing the innovation portal, which will be an online portal enabling innovation leads from across the region and in the NHS to see what each other are working on, promoting opportunities for collaboration within our system. Nurturing cultures. We often hear a lot about developing a culture of innovation, but that's no easy feat. And we found some aspects particularly crucial to this work. So, for example, patient and citizen voice should be at the heart of every innovation that we adopt. And as Emma spoke about, and Val and Sophia, the citizen participation group has been a really fundamental aspect of this, which resulted from the Adopting Innovation Hub. We also need to showcase our successes through events and innovation showcases to support spread. Creating an authorising environment. We've realised that the governance around innovation adoption is really tricky, And in order to support timely adoption and the development of innovation, we need new governance structures that support this and support sensible risk-taking. Thank you, and I'll hand over to Simon Howard, who is the ICS's Programme Director for Outcomes, and we'll talk about how the ICS have pulled together around CVD as a landing zone concept to progress innovation across the region.
So good morning, everyone. Can I just check everyone can hear me? I don't use Zoom very often.
Yes, we can.
Yes, you can. Okay, great. Well, okay, I will proceed. Let me just move my screen around for you. So next slide, please. So I should just introduce myself. So I'm Simon Howard. I'm the Programme Director for Outcomes within Strategic Commissioning. I've been with the CCG and then ICB for about 3.5 years. I come from aviation engineering background, so I have a slightly different take to people I generally meet within the NHS, and I tend to approach programmes with a more of an engineer's head than necessarily, obviously, a clinician's head, which I'm not. I'm going to set out what the purpose of the Your Healthy Future CVD programme was, but I understand this session is really a Q&A, so I really would like to encourage you all to ask questions. Please feel free to jump in if you'd like to, if you have something specific over the next few minutes. Just I'm happy to sort of go into detail in particular areas, just mindful of the time that we've got, that's all. So this is a 2-year programme from the point of launch, which was the 23rd of July this year. The idea was to target clinical and behavioural risk associated with cardiovascular disease, with the main priority of reducing major adverse cardiovascular events and premature mortality. The idea behind this, that we have a system called Eclipse, which is a risk stratification tool. It allows us to identify people who are at higher risk of cardiovascular diseases. It allows us then to engage with those patients on behalf of a practice, to text them twice, then follow up with a telephone call, which then means we can start to prioritise people into care pathways, ensuring that they get optimised care at the earliest possible opportunity. The model has been, think of it currently as a large-scale prototype for much bigger things, such as the new care model and health optimization part that Louis spoke to earlier on. But we have actually prototyped this prototype on 2 occasions previously around lipid management, once doing something with INHIP with our colleagues at HIE, but also something called COL 001, which was a QOF metric that we were using to try and optimize at the beginning of this year. And both of those test runs allowed us to find any bugs that we might see within the process that we developed. It's still not perfect, but we're developing it further. And the whole point of this is that we operate an iterative approach to improvement. So as we get feedback, anecdotally moving forward, we can then start to make adjustments to the content of the messaging that we do, or the comms that we're doing, try to improve the uptake and help work through that. Next slide, please. So there are 5 key strands to the first phase of this. Lipid detection and optimization, so building on that. That's the first one and the one that we've launched to the public so far. We're also doing NHS health checks, which is currently in late stage prototyping for us to launch in the next month or so. Hypertension detection and hypertension perfect, which are essentially detect and optimization, 2 separate pathways from our perspective, but really one gigantic pathway from everyone else. And then early next year, we're anticipating launching the BMI and personalized care pathway, which is around collecting data, particularly for people we suspect may have a high BMI, because we only have about 1/3 of patients with a recorded weight in the last 3 years. But then particularly to pick up any other comorbidities, ethnicity, preferred languages, family history in certain respects, that kind of thing. So we're trying, and we're going to use that in a way that's very different to the other pathways, in that we're able to code directly back into the GP record. So this whole process becomes automated, which is why that's at the beginning of next year, because there's some checking that's going on with that at NHS England. Next slide, please. So this is a high level and slightly glossy illustration of how the pathway works from the perspective of if a practice has signed up to something called Complete. So there are 2 pathways that a practice can sign up to within each of those clinical pathways. They can choose to do, well, they can choose to opt out entirely if they choose to. They can also choose to uptake something called Detect. And what will happen in Detect is where we will risk stratify their patient list to identify those we think are at the highest possible risk, and then provide that back to the practice, who then act upon that information and can get people at the highest priority into their care pathways as soon as possible. With the Complete model, which is what this illustrates, Eclipse, which is the provider we're using, will then start to make contact with those patients on behalf of the practice. And they'll do that through a text message or a telephone call and direct them into a landing page, at which point they'll be able to see videos around the use of statins, for example, within the lipid pathway. They'll be able to meet our friendly neighbourhood GP, Jessica, who's the clinical lead for this, where she'll talk through all of the different components of this. They'll be able to understand more about it. And then at that point, they're moved over to a questionnaire where they can make a determination as to what they'd like to do. If they don't respond to initial contacts, there's a second text message and a telephone call with a virtual hub that we have, which will then follow up with those people to allow them to have better information from someone who's a trained clinician. And within that virtual hub, if there's an escalation necessary, often they'll be referred over to a doctor who works for Eclipse, who will then be able to speak to it in even greater detail if necessary. That information is then cohorted into groups of people, and I'll just run through that in a second around what those cohorts look like. But once that's worked, we then take those people and we refer them back to the GP to do things like prescribing where necessary, but ultimately we've taken a huge amount of activity off the GP, freed up their time so they can focus on more complex patients and hopefully therefore optimize their patients for them. So that's the principle behind it. Next slide, please. So this is the data as of about a week and a half ago, but I'd actually like to just run through some other numbers that I've got. So I'm just going to talk to this rather than actually just reading through these numbers. So the number of patients that are within this cohort is slightly higher than what it says on the screen there is 5122. We're actually 5131. As of Monday this week, nearly 1,700 people had requested a statin as part of the lipid program that we're on. We had 562 people who'd requested a follow-up with our virtual hub staff so that they could have more information around that. And we'd had 72 people who'd actively chosen to discuss an alternative medication. And that's entirely expected because you have some people who are really well informed about different medications, and therefore they understand the necessary sort of options that they have in front of them. We also had, and this is interesting, about 1,252 people who decided to decline a statin. So that's interesting in that that's around about 24% of the cohort had determined that they didn't want to have a statin at all, and they've made that conscious choice. So we're going into detail to try and understand that. And then 28 people had decided that they weren't appropriate, had been told that they weren't appropriate due to comorbidities for the care pathway. Of those 1,696, so just short of 1,700 people, 563 people have now started on a statin. So from our perspective, what that means is we have potentially, of the 15% we anticipate, 85 fewer major cardiovascular events being prevented as a result of this program. So from our perspective, after 60 days of work, that's an enormous benefit and a huge outcome in terms of the care that we're able to deliver. In terms of the CVD landing zone, which is the next bit I'd just quickly like to talk about, this, if you take an engineer's perspective, this represents a model that can be replicated again and again and again. And we're already looking at this in other ways. So we're already working up a paper around potentially applying this approach to diabetes care management, which is in late stage development at the moment. We have a plan for familial hypercholesterolemia, which is easy for me to say, which is a much more nuanced approach to statins with people who have a genomic predisposition to have a high cholesterol level. And we're working on a respiratory program at the moment, all building off the same model that we're prototyping here so that we can optimize the health of our patients in a much more effective and efficient way. We do have some inequalities data around this. I'm not going to speak to it because we've had the first iteration of that, but at intervals, we're going to be monitoring inequalities as they exist. The first iteration of that is at the start of the program, and the inequalities you would see pretty much represent exactly what the common expectation would be in terms of people from deprived communities having poorer uptake, people from Black and ethnic minority groups having poorer uptake, that kind of thing. So we are going to iterate that on a kind of monthly or 2-monthly basis as the data can flow through. As it's early days, we're not expected to see a huge change at this point, but it does mean that we'll be able to see where we're missing people. The key thing here is that of the 522 people on the slide you're looking at, which was last week, 4,678 people had responded. There is a gap there of people who didn't respond or haven't received contact from Eclipse. The difference is, previously we called them hard to reach groups, and we sought out those people through demography, through information we had around exactly what I just said around expectations from health inequalities. But now what we have is an actual list of people that we have struggled to engage with. We have an active list of people that we can go out and try and seek in different ways using different models. We can cut that information against demography, so we can start to understand is there consistency there, but we literally know who those people are now. And that's the big change that we can make, because we're not doing generalized work in terms of uptake anymore to try and fill those gaps. We're now doing specific work to target those people. I think that's my last slide. So just next slide, please, just to see. No, that's it. Okay. So I'd be really happy to take any questions if anybody has any.
Thank you, Simon. Yeah, so we're going to go into breakout rooms in a minute, as you got a sneak peek there. So give you a chance. You've heard so much information, just give you a chance to reflect on that and think about it in your own context with a couple of prompt questions. Has anyone got any questions for Simon or anybody else on the team before we put you into breakout groups? Peer reflection time. Great. Julia, are we good to go?
Yeah,
Thank you for putting those prompt questions in the chat. Okay, brilliant. So we'll give you about 15 minutes in breakout rooms, 15 minutes or so. So you've got a good amount of time to talk. So feel free to use these prompt questions. Why do we need system-wide innovation to enable powerful, impactful decision making with finite resources? And what are the leverage points in your environment? You may also want to talk about what's stood out for you and your kind of key takeaways. We're going to come back after the breakout rooms to share a little bit about what you've talked about and get some key takeaways from the host team before we finish. So what would be great in the breakout rooms is if if somebody could volunteer to take some sort of high level notes to share back. We may not be able to hear from every room, but we'd like to hear from a few. And if somebody could volunteer to sort of lightly facilitate to make sure that everyone gets a chance to contribute if they'd like. So we'll leave you to self-identify once you get into the breakout rooms. So Julia is going to open some breakout rooms. Now you'll be invited to join as before. And again, if you'd rather have some solo time to think through and reflect on these questions, just stay in the main room if you'd like to do that. Welcome back, everybody. If I just ask you to go on mute as you come back in if you're not speaking. I hope those conversations were good. I'm eager to hear a little bit about what you talked about. I'm wondering whether I can invite anybody from room 2. Thank you. Anybody from room 2 who would like to share a little bit about what you talked about? What were your big takeaways or your reflections on the prompt questions?
I think we were in room 2. This is a bit of a test of actually, did you know which room you were in? So I'll do some feedback, assuming I was in room 2. No one's
Thank you.
That's right. So on the first question, we talked around some of the landscape issues around joining the dots up between different parts of the system and how in some ways that's become more challenging and difficult, particularly around people's space and time to dedicate towards this type of activity. The change from losing the structure that we had with CCGs and the ICS is coming in, and a sort of vacuum that's been left behind where there's sort of a lack of landscape that people meet up generally in, which makes forming those partnerships and joining up the dots between the different parts of the system slightly more challenging to do. And with that, the risk that there's a lot of reinventing the wheel. So there's lots of people forming little groups that are doing innovation, but they're not really joined up with other groups in a sort of wider sort of approach. So there's an element of people inventing and innovating, but then there's a lack of adoption because it's done in such a small scale or in such isolation that then it doesn't translate across into other systems or other groups. So that was the slightly negative side of the conversation, I suppose. And then the positive things around what could we do about it, we were sort of broadly talking about how can we get out of the silo working, and move towards a more collaborative approach, acknowledging that that's quite difficult because that's a cultural piece for a lot of organisations at the moment who have gone from being in competition with each other and competing for resources to now being asked to play nicely together and share those resources, which is a completely different mindset for a lot of those organisations. And actually we're in the early days of that in some places where actually that's in the way of being able to do this kind of work because people haven't got the maturity in those relationships yet to be able to do that. We're very short-termism, very sticky plaster. We look at solving the problems a bit too far down the stream rather than more upstream where we could do something a bit more proactive that might then enable solutions for health much earlier in the system. And as part of that, where's the engagement with social care and the co-creation and co-design with them? Because we acknowledge that a lot of the health determinants and health outcomes that one could look at come from lifestyle, housing, those other lifestyle things that are related to where people live and how they live, that actually healthcare needs to engage with more actively. I think that sums up a lot of our conversation.
That's great, thank you. And you're getting thumbs up from your sort of teammates in your room, and I can see lots of nodding from elsewhere in this large virtual room. I think we ended up combining a couple of rooms, and so I think I'd like to invite if there's any other reflections from room 5, I think. If you're aware that you're in room 5 and you would like to share some reflections, that would be great.
I'm happy to start, but we didn't actually answer. Actually, Lisa, you might want to start because it was your question. You might be the better person to respond.
I'll kick us off. We had a few tech problems, so slightly shorter discussion, and yeah, I think we roamed around the questions, but we had useful conversation. So we began because it was something I've been struggling with do we need to be clear about the difference between innovation and improvement? Innovation sits in my title alongside improvement, but I would say it's silent. So we just explored that a little bit about what do those two definitions mean for each of us, and how much does it matter. And then I think a key message that was coming out for some of us as well was that need to forecast and plan ahead. Breed, you use that lovely analogy of, we need to think about turning the tap off and not dealing with the flood right now. So that message we heard about knowing what our population will look like in 5 or 10 years and how can innovation help us. We had a piece around that. Breed, what else would you add?
It was just, I guess, Edmund's point, because we were talking about virtual care as an example of the tap and the flood. That if we wanted to move to a less paternalistic model where we activate patients and enable them to self-care in a supported environment, which I think is where the huge opportunity lives, we need to really think about how we make that easy for our patient groups and some of the barriers to that, perhaps.
Great, thank you. Before I invite final reflections from Louis, is there anything else that anybody wanted to add or ask before we move into the reflections from the host team? Oh, yes, Breed.
Louis, I was delighted to. One of my things I do is I'm on the board of trustees for Barnardo's UK. So obviously, children, and particularly related to deprivation and poverty, is really big on my mind. And I go to lots of health improvement conferences. I go to tech conferences, and rarely, even when we're talking about population health, do children feature. And yet, if you look, you mentioned some of the things that happen with kids. The rate of obesity, type 2 diabetes in young people is off the scale. And actually, we've got a tsunami of long-term conditions. How do we change that we really start talking about, not just dealing, again, it's the analogy of the flood and the turning off the tap. It's your views, because I was delighted you had something in there.
So I think the conversations kind of we've had in our group, probably just to kind of link back to that, is one, I think we've got a massive opportunity to change things. Two, it has to come with a different conversation with our population, as someone else mentioned, kind of patient empowerment, much more information and a different kind of conversation. We reflected quite a lot on the kind of the end of life space, for example, but I don't think it's different for children. Actually, we're all seeing the statistics, so there's lots of things that we could do to intervene, but actually we'll also need our population and other parties to kind of play into that in a big way. And we're doing a lot of work locally around kind of behavioral science and some of the other things to really just understand, some of these choices. I also think we're having some very crunchy conversations, for example, on children specifically, about the environments that we put in place. And it's really interesting. Just on Friday, we've had a conversation with our kind of planning leads across our kind of local authorities and district councils. And just hearing from them about some of the barriers that they have, because from a health perspective, I'm like, I stop opening some of these places and stop creating the environment for people to kind of go into. But actually, once a year from them, some of the barriers and that they are facing actually is really interesting. And it just all for me comes back to, the outcomes framework that I talked about is something that is not a health thing. It's something that we collectively as a system signed up to. And what we're trying to do now in our conversations is really crunch down and have difficult conversations about how do you actually change it. Let's not have words on the page because it doesn't matter and it won't have any impact. But when you really get into it, we are stacking the system, some parts of our population, in such a way that you will never change those outcomes unless you start changing. It has to be all the different facets. And so I think there's that, but it needs people to pull together, and it needs different decisions. We're not going to change this by making the same decision. So as I, sort of call it, what I always say in our system is, you don't get a gold star for mentioning health inequalities in the system or in a meeting. You get a gold star for making a decision that's going to actually impact on health inequalities. And I think it's the same with children. I suppose my reflection on this is, and we've talked about this in the group, is we are, the conversation with patients needs to be different. We talked a little bit about data and the capabilities that we've got now that we haven't had 5 years ago to really intervene in different ways. But we also recognize, certainly in our system, that patients are quite scared of that, because there is a whole thing, something negative about the use of data, even if it's in a responsible way to kind of change their healthcare. Because we never hear good stories about data. All you ever hear in the news is, something's been leaked and patients of the population have been compromised in some way. So I think that needs to change. But I think, and hopefully what has landed today is, I think we've got such opportunity, because we always hear about, the brokenness of our systems. But actually, when you look at the data and you look at the opportunities, they are enormous. But again, it does need us to focus on the sort of today's stuff, which we know we need to. But it need to get into that kind of space about changing things for the kind of medium and the longer term. Otherwise, the crisis of today is never going to get better. And I think that's going to be the challenge for health systems and for care systems going forward as well. And I'll just say this: the more we go into this, the more we recognize that the pressures that will drive health is the same things that will drive pressures in care. And it's the same, and actually that if that doesn't pull us together to say that we need to do something different, then I don't know what will. Hopefully that's helpful.
Thank you, Louis. And I feel that that's partly your answer to the question that you posed to the rooms as well. Is there anything else that anybody else from the host team and partners would like to add to Louis' reflection just then? I'm just checking a message in the chat. Scott, innovation framework. Do you want to say anything more about that?
I was just responding to what, because I found that very interesting as an approach as to how you could then bring some parts together in a wider system, and how it could be an enabler rather than what tends to be happening is a yes/no group that people put in and put barriers in place in terms of governance, rather than an enabling framework, which I felt that was a very good example of. So I'm quite keen to see how we might make that work in the southwest where I am.
Brilliant, thank you. And Emma's just put in we can share our working version. That's really generous. Thank you, Emma, and thank you for the comments, Sophia and Breed as well. That's a really lovely, positive way for us to round up. There is opportunity. Let's use it. And clearly, this has been inspiring. People are thinking big and challenging the existing mindset, and that's been lovely to hear. So I would like to say a huge thank you to all of the speakers and the partners working across the system that we've heard about. We have we want to do our own improvement on these visits, and we have an evaluation survey. I'm sure you won't be surprised to hear. I have popped it in the chat already, but I wonder if Julia might pop it in again as well. We'll also send it around again afterwards, but if you are able to click on it now and respond while it's fresh in your head, that would be wonderful. We also have thank you, Emma. We also have more Q visits coming up, and we're always announcing more. So do check the website for those, and you can see what else is coming up. I think our next one is on sustainability in healthcare with SUSQI, coming up in early November. So thank you all so much for all of your contributions, all of you who have spoken, and all of you who have contributed in the breakout rooms. It's great to have all of your input into the session. So thank you so much.
Thank you.
Thank you.